Here's something I've been thinking about, and honestly, I wasn't sure whether to make this video, because it goes against a lot of what's become popular to say. And I know some of you are going to push back on this. That's fine. I'd rather have that conversation than keep pretending there's a clean, comfortable answer. So let's talk about therapy, mental health care. The whole industry has exploded in the last decade. You can't scroll through any platform without seeing someone explain how their therapist changed their life or how finding the right coping mechanism finally helped them break free from their past. And that's real. I'm not disputing that therapy helps people. It does. But here's the part we don't talk about. For a significant portion of people who enter therapy, researchers put the numbers somewhere between 30 and 50%, depending on the study and condition. It doesn't produce meaningful improvement. Some research shows a small subset actually get worse during treatment. Not because they didn't try hard enough, because therapy, like any human system, has real limits, and the wellness content economy has enormous financial incentive to not say that out loud. Before we go further, if you've been in therapy for months and feel like nothing is shifting, or you've wondered whether the problem is you, this video might reframe some of that. Subscribe if you want psychology content that actually engages with the uncomfortable parts. We don't do validation theater here. I want to be clear about what I'm not saying. I'm not saying therapy is a scam. I'm not saying you should stop going if it's working. And I'm definitely not platforming the just think positive crowd who use criticism of therapy as cover for telling people to gut it out alone. What I am saying is that therapy has been sold, particularly to younger, digitally native audiences, as something closer to a guaranteed process than the genuinely complex, variably effective intervention that the clinical literature shows it to be. And understanding why it sometimes doesn't work isn't defeatist. It's actually the most useful thing you can know before you spend 2 years in a therapeutic relationship that isn't the right fit. The relational layer problem, and why it's more complicated than find the right therapist. Relational layer. The single strongest predictor of therapy outcome isn't the type of therapy. It's not CBT versus psychodynamic versus EMDR. It's the quality of the relationship between the client and the therapist, what researchers call the therapeutic alliance. That's been established fairly solidly since the 1970s. Borden's original work on the alliance, later replicated across hundreds of studies, consistently shows it accounts for a meaningful chunk of outcome variance. Here's where it gets complicated though. The alliance is bidirectional. It depends on the therapist, yes, but it also depends significantly on the client's own attachment patterns, their capacity to tolerate uncertainty, whether they've learned to trust or distrust authority figures. Someone with a history of relational instability often has the hardest time building the very thing that makes therapy work. And this isn't a flaw in the person, it's a genuine methodological limitation in how we've designed the intervention. We're asking the population most likely to have damaged trust to repair themselves through trust. The research acknowledges this. Most therapy content on the internet does not. I'd also note, find a better therapist is advice that costs time, money, and often a fairly destabilizing period of transition. It's real advice, but it's not cost-free advice. 2. Insight isn't the same as change, and for some people, it makes things worse. Psychodynamic and psychoanalytic approaches operate on a foundational premise that making the unconscious conscious produces change. That understanding why you do something will eventually help you do it differently. That works for some people. For others, and this is documented, increased insight into their patterns produces increased distress without increased capacity to change. They become sophisticated narrators of their own suffering without becoming less burdened by it. Jonathan Shedler, who has published quite a bit on the efficacy of psychodynamic therapy, would probably push back on this characterization. And his meta-analyses do show meaningful effect sizes. But the effect size in a meta-analysis is averaged across everyone who responded, including people who responded strongly. It doesn't tell you specifically will respond. Some therapists are now explicitly cautious about insight-heavy work with clients who have what's sometimes called high emotional reactivity, where revisiting and naming pain reopens it without building the regulatory capacity to sit with it, There's an argument that body-based approaches, behavioral activation, or even structured routine building should come first in those cases. The field isn't fully settled on this. I find that uncertainty genuinely interesting. I think you should too, instead of being handed a framework that pretends we have it figured out. 3. The diagnosis question. Sometimes the label is the cage. Identity layer. This one is shorter, not because it's less important, actually the opposite. Psychiatric and psychological diagnosis has significant clinical utility. It allows treatment matching, insurance coverage, research categorization. None of that is trivial. But there's a documented phenomenon in the literature called diagnostic overshadowing, where once a person carries a label, everything they experience gets filtered through it. Anxiety becomes part of the anxiety. Grief becomes part of the depression. Legitimate situational responses to genuinely difficult circumstances get medicalized. I'm not anti-diagnosis. I'm saying the diagnosis is a map, not the territory. And some people spend years in therapy treating the map.
4. What the dropout research actually shows and why therapists rarely talk about it. Somewhere between 30 and 60% of people who start therapy drop out before their therapist would consider treatment complete. The range is that wide because dropout is defined inconsistently across studies. Some count anyone who doesn't reach a formal termination session. Others require a minimum number of sessions before counting someone as having really started. When researchers have followed up with early terminators, the picture isn't simple. Some left because they felt better. Some left because they felt worse. Some left because the practical barriers, cost, scheduling, transportation, were simply insurmountable. And some left because they felt fundamentally misunderstood and didn't know how to say that to the person they were paying to understand them. That last category is the one that bothers me. Because the therapeutic frame, where the therapist holds authority and the client is the patient, can make it genuinely difficult for people to advocate for themselves inside the room. You're supposed to trust the process. Questioning the process can feel like resistance, and therapists, being human, sometimes interpret client pushback as pathology rather than feedback. There's no neat resolution to this. It's a power asymmetry built into the structure of the relationship. Being aware of it is about the most useful thing I can offer. I want to pause here and be honest about something. Everything I've said so far could be read as ammunition by people who already don't want to engage with mental health care, and that worries me.
Because the answer to therapy has limits is not don't go to therapy. Untreated depression, untreated anxiety, untreated trauma, these have consequences that are well documented and serious. The literature on what happens to people who receive no intervention versus imperfect intervention is not ambiguous. So this video isn't a permission slip to avoid getting help. It's an argument for going in with accurate expectations, knowing how to evaluate whether something is working, and understanding that if it isn't, that failure has multiple possible causes, not all of which are you. That distinction matters. I think you're capable of holding it. Also, and I mean this, if you're in genuine crisis right now, this is not the video for you. Please reach out to a crisis line or go to an emergency department. The content here is for the long, complicated middle of mental health struggles, not the acute sharp end. The wellness economy's incentive problem. Who profits from your healing being a process? Structural layer. This is the section that will make some people uncomfortable. Good. Therapy, as it's currently structured in most Western markets, is a fee-for-service model. The therapist gets paid per session. There is no financial incentive, and I want to be careful here because most therapists are genuinely trying to help people, but structurally there is no financial incentive for brevity. Contrast this with something like CBT, which was specifically designed as a short-term protocol with defined endpoints. The original cognitive behavioral work by Beck and colleagues was built around 12 to 20 sessions. Yet many people receiving CBT in private practice settings stay for years because the model has drifted away from its protocol basis and toward indefinite supportive care. Is indefinite supportive care bad? For some people, no. It's genuinely what keeps them functional. But it's worth asking whether it's ever framed explicitly as an option against which alternatives are compared, or whether it just becomes the default. The wellness content economy has a related problem. Psychology content on social platforms, and I'm including what we do here, I'm not exempt from this, is rewarded for producing engagement. Validation produces more engagement than challenge. Reassurance outperforms uncertainty. You are not broken performs better than this is complicated and the research doesn't have clean answers yet. That's a structural incentive toward producing exactly the kind of content that makes people feel seen without necessarily making them more accurate about their situation. When therapy is genuinely the wrong tool and what the evidence points to instead. Evidence layer. For certain presentations, the evidence for alternatives is actually stronger than the evidence for traditional talk therapy. Not stronger than therapy in general, but stronger than talk therapy specifically. Exercise and depression is probably the clearest case. The research here is surprisingly robust, including a Cochrane review pulling together randomized controlled trials that showed aerobic exercise with statistically significant effect sizes for mild to moderate depression. Comparable in some studies to antidepressant medication for certain populations, though with substantial heterogeneity across studies that makes comparable a complicated word. Sleep intervention for anxiety is another. Improving sleep architecture through behavioral protocols rather than medication has downstream effects on anxiety severity that aren't minor. Yet, how many people in therapy for anxiety have had a detailed conversation about sleep stages, sleep pressure, and the specific behavioral changes that affect them? Social connection, genuine, reciprocal, non-transactional, has effect sizes in the longevity and well-being literature that dwarf almost everything we discuss in individual therapy. Julianne Holt-Lundstadt's work on social isolation and mortality is some of the most striking public health data of the last 20 years, but Get Better Friends doesn't have a CPT billing code. None of this means stop therapy. It means therapy is one tool. It's often not the only relevant tool, and sometimes it's not the most powerful one available for your specific situation. So here's what I'd actually suggest. Not as a protocol, just as a posture. If you're in therapy and it feels like you're spinning, name that explicitly to your therapist. Not as a complaint, but as information. A good therapist will engage with that seriously. If they can't, that's data. The most honest thing I can say is we're all working with incomplete maps. The goal isn't to find the one that's perfect, it's to know which edges of your map are reliable and which ones are still guesswork. Subscribe. If you made it here, genuinely thank you. This wasn't a comfortable video to write, and it probably wasn't a comfortable one to watch. Subscribe if you want psychology content that respects your ability to handle nuance. We cover what the research actually says, including when the research is limited, conflicting, or just honest about not knowing yet. That's rarer than it should be. We're trying to do it anyway.